See if we can get this into presenter mode. There we go. All right. Hopefully the people on Zoom can also hear me. Dr. Dye, I think you're on Zoom. Are you hearing me currently? All right. Yeah, thanks, Dr. Dye. All right. So my name is Harrison McUmber. I'm one of the second-year emergency medicine residents at the University of Utah. I'm really excited to be out here and to meet you guys and see how you practice and teach you a little bit about ultrasound. So thank you so much for having me at your hospital. I really appreciate it. So this is going to be a pretty brief overview of the rush exam. And then hopefully maybe we'll get some hands-on teaching to practice ultrasound and practice some of the components of the rush exam today. But this is the overview of the talk. It'll cover some of the basics, which you all probably already know, just the components of shock, what the rush exam includes, and then going into more detail about each of those aspects. So the heart, the inferior vena cava, the fast exam, the pulmonary exam, the aortic exam, and then hopefully a little bit of time to practice on each other using ultrasound hands-on, which at the end of the day is really the best way to learn this exam. Let me remove this. That should work. So just a quick definition of shock, as we all know, kind of this is a lack of oxygenation or perfusion to end organs in the body. And we can see that on labs and things like that to kind of determine if a patient is in shock. I feel like this might have, okay. So the different, I don't know why it's popping up. The format is a little bit off here. So the different buckets of shock that we typically think about is cardiogenic shock. So when the pump is not working, when the heart's not really working the way that it should be, that can be due to heart failure or a massive heart attack leading to wall motion abnormalities and really leading the patient to not have the ejection fraction that you would expect or that can perfuse the rest of their body. And then distributive shock, most commonly, and I feel like probably the most common cause of shock that we see in our emergency department and probably most emergency departments around the world is sepsis. Yeah. Oh, for sure. Yeah, that sounds great. I'm not sure how to get that thing out of the way.
Recording in progress.
That's perfect. Other causes of distributive shock that we don't see as often is neurogenic shock. If somebody has a cervical spine injury or a high thoracic spine injury. And then anaphylaxis is another type of distributive shock. Obstructive shock, we think about most commonly pulmonary embolisms, but also cardiac tamponade and tension pneumothoraces. In patients with, you can have hypovolemic shock, and I think most commonly, especially in your emergency department, where it seems like you guys see a high volume of trauma patients, is probably hemorrhagic shock. And then also dehydration and dysentery and things like that, patients who are really volume down or volume depleted. Try that again. There we go. So the rush exam overview, I think when we have a patient with undifferentiated hypotension, and that's really why we want to use the rush exam. So just to start with kind of the basics is if you have a patient who comes in and they're tachycardic and have low blood pressures, they're hypotensive, they look like they're not perfusing their organs appropriately, maybe they have altered mental status. That's really, and you know nothing about these patients. Maybe you say your ambulance just brought them in, you have no medical history, have no idea what's been going on for the last several days or hours. That is the perfect scenario to use the rush exam. And when we have no information, just like anything else in emergency medicine, we want to have kind of a stepwise approach of doing things. And, we do it in that same order every time so we don't miss anything. So the mnemonic that I use for this situation is HIMAP. That helps me remember how I'm going to go about the rush exam. So I'm going to first start with H, and that's going to first start with the heart exam. And then I'm going to go to the IVC. And then M stands for Morrison's pouch, but I think most people are going to be doing a full fast exam for free fluid in the abdomen. And then the aortic exam and then the pulmonary exam. So to start out with the heart, the views that you'll kind of want to get, you don't have to do all 4 views when you're doing a cardiac exam for the rush exam. I usually just do the parasternal long axis and then the apical 4-chamber view. With the group I talked about yesterday, unfortunately in the US, we have a big problem with obesity. So sometimes the apical 4-chamber view is not as easy as I would like it to be on my patients that are larger. And so I'll go to either the parasternal short to get some of that information or do a subxiphoid view, which can sometimes be a little bit easier. Causes of shock that we're looking for on the heart exam are pericardial effusion, like this patient has here. You can see in the bottom left corner that little arch of fluid around the heart. And then we're looking for signs of cardiac tamponade. Does anybody know what signs we're looking for on ultrasound that may indicate that a patient's in cardiac tamponade? I can also just tell you and we can talk about it later. So kind of the big one that I look for a patient that's in cardiac tamponade is right ventricular diastolic collapse. So when that patient's in diastole, you see fluid around their heart. You try to figure out when that patient's heart is in the diastolic phase. And if that right ventricular wall is collapsing in diastole when it should be filling, that's kind of telling me that a patient may be in cardiac tamponade and their effusion might be the cause of their shock. What might right ventricular enlargement indicate on an ultrasound? Yeah, be concerned for a pulmonary embolism. So if a patient has pulmonary embolism and they basically have a lot of right heart strain, the right side of their heart is working really hard to push that blood past the pulmonary embolus. It's going to dilate and look really big. And we'll kind of talk about that in a couple more slides. Other things that we can look for is hypodynamic left ventricles or hyperdynamic left ventricles. Hypodynamic, it's really not working as hard as it should be, or hyperdynamic is it's really working too hard, trying to overcome some other form of shock. And so first thing to start is the right ventricle enlargement. I think that this can be a pretty tough exam finding to identify on ultrasound, just because you really need a good view and you really need to make sure that you're slicing the heart right in the middle. If you get sort of a slice of the edge of the heart or it's off axis in any way, it can either falsely reassure you or it can falsely make you a little bit more concerned than you should be and make the RV look a little bit bigger than it is. And this is best assessed in the the apical 4-chamber view, which you can see here in this image. Luckily for us, the chambers are labeled there, and so we can see that right ventricle is really big compared to the left ventricle. Typically, the right ventricle is less than 60%, less than 2/3 the size of the left ventricle. So this is very abnormal. And you see the right atrium is also very enlarged, and that's due to just those increased pressures in the pulmonary vasculature that right side of the heart is pushing against. And then the left side of the heart. So things that we can look at in the left side of the heart, and this is typically most easily assessed in the parasternal long axis view. We can see if the heart is hypodynamic or hyperdynamic. Hypodynamic hearts, and we've probably all seen patients' hearts that are in heart failure, and they just don't have very strong hearts to begin with, and it really just looks like that heart is barely moving at all. And they might have a poor ejection fraction. They might have poor EPSS or endpoint of septal separation. That mitral valve really isn't moving as far or as close to the septum as we think it may, or that it should, which suggests to us that patient has a poor ejection fraction. Other aspects we're looking at is hyperdynamic heart. If a patient is in sepsis, then that heart is really squeezing and it's got a greater than 90% change in the size between systole and diastole. That means that heart is working really hard to overcome potentially a distributive shock situation. And then moving on after the heart, if we take a look at the heart and everything looks normal, or if we see some signs on the heart that maybe this suggests signs of tamponade, maybe suggests signs of pulmonary embolism, this is a great exam to do next to kind of confirm or disaffirm your beliefs that patient might have a PE or tamponade. So looking at the IVC here, one way first, just to kind of talk about identifying the IVC, which I think can also be challenging. Sometimes, you find a big vessel going down their abdomen and you may be looking at the aorta and you're not sure if you're looking at the IVC. Two ways that I use that can quickly help me identify that I'm looking at the IVC versus looking at the aorta is one is the IVC should drain directly into the right atrium. So if you have that subxiphoid view and you tilt the probe up and you take a look at that heart, that vessel should be leading right into the heart, which you wouldn't see based on the anatomy for the aorta, which kind of, as we all know, comes into the heart kind of more superior as opposed to the inferior IVC going into the right atrium. Another way, which this image actually shows, is if we see that diagonal vessel going through the liver, that's the hepatic vein. And the hepatic vein should connect directly to the IVC, which then goes into the heart. And for me, that's the one that I use most commonly is I can see that hepatic vein draining into the IVC, and it tells me that I'm looking at the IVC and not the aorta. So things that I'm looking for when I'm looking at the IVC, I'm looking at the size of the IVC and how it changes with inspiration and expiration. So typically in a normal patient who doesn't have any pathology, you're going to see some change in the size of the IVC with inspiration and expiration. When a patient inspires, their intrathoracic pressure goes down and that draws blood from the IVC into the heart, and that IVC should shrink down a little bit. And then when they exhale back out, it should get a little bit bigger. However, when you have a patient with an obstructive shock, say with tamponade or pulmonary embolism, that pressure is not going to change as much, and all that blood that should be getting into the right heart and going to the lungs is going to get backed up into the IVC. So the IVC is going to look really big, and it's not going to change very much when that patient inhales and when they exhale. And then on the other end of the spectrum, if we have a patient who's really hypovolemic or if they have a form of distributive shock, then they're going to be very volume down, or at least relatively volume down. So when they take a deep breath in, that IVC is going to completely collapse. And then when they take a breath out, it might come back a little bit, and then they take a breath in and it collapses again. So that tells you the patient might be hypovolemic or might have distributive shock, and that patient can tolerate fluids. Oh, and last point that I wanted to mention that I feel like has been challenging for me. I know at the University of Utah, at least, we have a lot of our patients will arrive to our emergency department already intubated. Say they were in a serious car accident, and then Life Flight or the helicopter service will pick them up from the scene of the accident and then bring them into the hospital. But that while they're in the helicopter en route, they'll become unstable and need to get intubated along the way. And so if you have a patient that's already intubated, that kind of negates the reliability of your IVC exam. Because the big difference being that when we're not intubated and we're breathing, we're spontaneously breathing, we're breathing through negative pressure versus positive pressure. And when a patient's being positive pressure ventilated, this exam is not as reliable as it is otherwise for evaluating things like PE or tamponade. And then moving on, after we do the IVC, we're going to go to the FAST exam. And I'm sorry if all of this is review for you, but the most sensitive location on the FAST exam is the right upper quadrant for free fluid in the abdomen. So that's always the place that I jump to first. And we really want to make sure that we're seeing that kind of edge between the kidney and the liver, which is called the hepatorenal recess, or in America, it has the eponym of the Morrison's pouch. And then we also want to see the liver tip. And if we can see all of those structures and we don't see any free fluid, then we can be pretty reassured that patient doesn't have any free fluid in their abdomen. So when I see a patient who's in shock and they have free fluid in their abdomen, things that I'm thinking about are, if it's a younger female patient, I may be thinking about an ectopic pregnancy. If a patient has bad vascular disease, maybe a known aortic aneurysm, then you may have a ruptured AAA, or they could be having a ruptured dissection, ruptured bowel, or if a patient has massive ascites and rapidly accumulating ascites, they can be in hypovolemic shock because all their intravascular fluid is being lost to their abdomen. All right, so we're moving on to the aorta here. So the aorta, I also could find can be a challenging exam, particularly when a patient is obese. Going through cutaneous fat and maybe some bowel gas, and it can be difficult to see the aorta. When you all are doing a aortic ultrasound, what landmark do you typically use to find the aorta? So for me, I think the easiest thing that
You can observe the outer wall of the aorta,
the what?
the outer wall.
Outer wall, yeah. Yeah, you can see the outer wall. That's definitely what's going to show up easiest on ultrasound. And I know this is kind of a read my mind question, so I apologize. But for me, I think the easiest thing to find is actually the spine. So if we see in the blue lettering there, the spine, which is just deep to the aorta, it's going to have that bright anterior longitudinal ligament that's really going to reflect a lot of sound waves. So that's going to be a bright line on the spine, and then you're going to get shadowing behind the spine. So if I'm able to find the spine, then I know the blood vessel right superficial to the spine is likely going to be the aorta, as long as I'm not looking at the IVC. And then something that's helpful to distinguish between the IVC and the aorta on this exam is to turn color flow on, and you should have strong pulsatile color flow through the aorta when you're getting a good view like this. And so we're scanning the aorta for, say, a ruptured AAA or a ruptured dissection. The four views that we want kind of the subxiphoid view right below the thorax here, and then right above the renal arteries, right below the renal arteries, and then we want to scan down and see when that aorta splits into the iliac arteries. And that really assures us that we've looked through the entire aorta and we're not missing anything along the way from the exam. This is typically done in the transverse view, like you can see here, where you're taking cross sections of the aorta going down the abdomen. But I've found that when I maybe think something is abnormal about the aorta, I always flip it into longitudinal view. And if I can get a good long view of the aorta, maybe I'll see a little bump or a rise or a dissection flap to either confirm what I think is going on or make me a little less concerned about something I think I might have seen in the transverse view. And so we want to be measuring outer wall to outer wall. And this will really come in handy because if you're measuring inner wall to inner wall, you can be falsely reassured. Say somebody has an aortic dissection and they have a dissection flap within the aorta with a blood clot or a thrombus inside, and you're measuring inner wall to inner wall. That can make the diameter of the aorta falsely smaller than what it actually is. So we want to make sure that we're measuring outer wall to outer wall. And at least for the numbers that we use in our emergency department, is if a patient has a aorta that is greater than 5 centimeters and they're showing signs of shock, that's a ruptured AAA until we're able to prove otherwise. So that's certainly a patient. If they're stable enough, I'm going to send to the CT scanner to get a CT angiogram to take a closer look at that aorta. Or if they're unstable, I'm going to be calling vascular surgery or cardiothoracic surgery to come evaluate the patient immediately. And then moving on to the pulmonary exam, and this is kind of the most straightforward, in my opinion, of all of the exams. For anyone who's done lung exams, there's not too many things you're looking for. Really, the main things that you can look for in a lung exam is lung sliding, and if they don't have sliding, you maybe think that patient has a pneumothorax or a hemothorax or a pleural effusion. And we can also look for B lines in our patients with heart failure if they have severe pulmonary edema. But really what we're looking for, I think, is the pneumothorax or hemothorax or big pleural effusion that's causing tension physiology. Is that pathology bad enough to where it's compressing the IVC and inhibiting venous return back to the right atrium? And then it's always nice once you find this to kind of confirm that with a stat or a quick chest x-ray. So just to go back over the basics, high map is something I always think of. I know when, you have a critical patient coming in and they're hypotensive and tachycardic and, looking very sick, it's a very stressful situation. And I think all of us, we lose some IQ points in that scenario when we're trying to deal with very sick patients like this. So having an easy way, such as high maps, to remember, okay, these are the ultrasound exams that I need to do, and I typically do them in this order. And I think that is it in this talk. If anyone has any questions, we can kind of talk about the more specific, like each component of the exam in more detail. But I know that we had also talked about potentially doing some hands-on practice of the exam, and I think that is really the most beneficial in terms of getting familiar and comfortable with the rush exam.
Có câu hỏi gì không? I get the patient get the traumas come to emergency department. So he's hypotension. I check the ultrasound. We have the fluid in the abdominals, maybe internal hemorrhage. And then we do the ultrasound. I check the syringe rupture. Should I do blood infusion or change the patient to the CT scanner to find the position reading to do vascular intervention, or invite the doctor specialist come to ED to decide to operate, cut it off?
Yeah, it's a good question. And I think in our emergency department, so say we have a patient, like you said, who comes in as a trauma patient. We know a patient was in a motor vehicle accident or something like that, and they're in shock, so they're hypotensive and tachycardic, and we find free fluid in their abdomen. Yeah. I think per our protocol, that's an indication for that patient to go directly to the operating room. Mm-hmm. As if they're unstable, then an exploratory laparotomy is kind of our first go-to, or at least that's what our trauma surgeons will do. Just open them up and try to find the source of the bleeding. But if a patient is stable enough and they can go to the CT scanner, I think that's also ideal, because like you said, if somebody has a splenic laceration that they can be embolized for versus getting an entire exploratory laparotomy, I think that's ideal in a stable enough patient.
Yes.
Các bạn có câu hỏi gì đâu, hỏi đi.
Dr. Kiệt, he is a student of Utah University now, and he likes to use ultrasound on severe case in our department. So I think he have many experience about that. So Dr. Kiệt share everybody about some appearance when you use ultrasound, rush ultrasound, fast ultrasound in trauma patient and severe patient in our department.
Wait, I think I misunderstood. What was it a question or?
When I receive patient, especially severe patient, respiratory failure, chest pain, I always use ultrasound to evaluate that patient first.
Yeah.
And I use rush ultrasound, fast, and also blue protocol for respiratory acute respiratory patient.
That's great. Yeah, we use it all the time too. I mean, even if a patient isn't critical and they have chest pain and maybe maybe they have some lower extremity edema, they have signs of heart failure, I'm taking the ultrasound with me too, just to gather the little bit of information that I can. I feel like it's a really useful tool even when a patient isn't severely ill.
Mm-hmm. When patient with severe chest dyspnea, severe dyspnea, mm-hmm. They usually didn't talk clearly about history medical.
Mm-hmm.
Mm-hmm. And I usually do protocol. I use ultrasound and use blue protocol to determine why is the patient why the cause of dyspnea
of the dyspnea.
Yeah. For example, OAB. Yeah. pulmonary edema,
Yeah, I can see the
pneumonia,
beelines. Yeah.
sometimes pneumothorax,
Hmm.
and PE.
Yeah.
Yeah.
Absolutely. Yeah. It's very helpful for all those things. I think the ultrasound in conjunction with the chest X-ray helps a ton. Using them both individually is not as helpful when you can kind of combine a chest X-ray and an ultrasound. It's very helpful.
And I have a question. Yeah. This Rush protocol can have we determine why is the patient in shock and what type of shock. But we also have some invasive. This is a non-invasive method. We can use bedside, but when compared with invasive method such as PE catheter or flow duct. Could you tell me about pros and cons of this method and invasive method?
For identifying pulmonary embolism, you say the pulmonary, which catheter?
PE catheter, PA, no, PA,
Oh,
pulmonary artery catheter.
okay.
Yeah, and flow duct.
Yeah.
Yeah.
Are you using that like as a diagnostic method, the PA catheter?
I've
what do you
never seen this before.
Yeah.
But I read textbook. I see that.
Yeah. I don't think I've never used like a PA catheter for like the diagnosis of say like pulmonary embolism. I think.
No embolism, but determine what type of shock.
Okay.
And we need to follow. We need to evaluate hemodynamic.
Yeah, I think that's not. I think most of the time between an ultrasound, labs, and maybe a little bit of history, we can typically determine what kind of shock the patient is in, unless it's like a very complex situation. I think I don't have a ton of experience with the PA catheters because that's something that would typically happen once a patient is admitted to, say, like the cardiac ICU. They'd be floating like a Swan scans catheter or something like that to really measure like pulmonary capillary wedge pressures and things like that. And that's just typically not something that I would do in the emergency department. Yeah. So I think that's helpful down the line and maybe not as helpful on initial assessment. At least we don't use it in our emergency department. Yeah.
Sorry, is there anything we need to notice? The patient got pregnancy.
In pregnancy?
Yeah.
Yeah, I think especially like I mentioned before, if you have a patient who comes in and they have severe abdominal pain and they're pregnant, the things that I'm doing is first I'm using an ultrasound to look for an intrauterine pregnancy. It's pretty straightforward and simple to just take a look at the uterus with an ultrasound and make sure that pregnancy is in the uterus. And then if they have a positive pregnancy test, I can't see the pregnancy in the uterus and they have free fluid in their abdomen, that would make me incredibly concerned for an ectopic pregnancy, in which case I'd probably be calling obstetrics to do potentially like an exploratory like laparoscopy to figure out if that patient has an ectopic pregnancy. And we also have more formal, like say transvaginal ultrasounds that we can order in our department that just gives you a much better view to make sure that patient has an intrauterine pregnancy or not. Yeah. Does that answer your question?
Yeah.
Okay.
In pregnancy patient, when we use Rush ultrasound and aorta, when pregnancy in second or third trimester, I think it have a little bit. It's a little bit hard.
Yeah.
When we use ultrasound to evaluate the aorta.
I know. Yeah, you have something blocking your view there, and that's tough.
About your experience in that patient, what what type method you use to evaluate
Yeah,
aorta?
I think that's a really hard question. I don't think I've ever been in a situation where I have a second or third trimester patient who I'm that concerned about aortic pathology. I mean, pregnant patients are at higher risk for vascular complications, but typically that's not high enough on my differential. And I think the only way to really get a great view in that situation is doing like a CT angiogram, which is also not a great thing to do, is expose a pregnant patient to radiation. That's a good question. I've never been faced with that kind of dilemma. I think typically in younger women who are otherwise healthy, I have a lower suspicion for like aortic pathology on, so I haven't had to go down that rabbit hole, I don't think.
Yesterday, we have a patient like that.
Oh, really? Oh, no. That's challenging.
Yeah.
And you were concerned about this patient's aorta, and she was in her second or third trimester.
Patient admitted with lower back pain.
Yeah.
And it's ready to upper right quadrant.
Mm-hmm.
After that, she got severe dyspnea with pulmonary edema.
Oh, wow.
Yeah. And when we first received the patient, we care about why this patient had pulmonary edema.
Yeah. I feel like
Plus, we also think about heart failure, acute heart failure.
that'd be my thought in that patient is heart failure.
Myocarditis.
Yeah.
Or something like that.
Because you can see pregnancy associated.
But when we use ultrasound, we see the rope of aorta a little bit larger.
Dilated.
Yeah, dilated. And uncontrolled hypertension before about medical history.
Yeah.
And so we take her to evaluate a CT scan, and CT scan show that she has a type A recession.
Really?
Yeah.
Yeah. I mean, I think in that case, the benefits of the CT scan outweigh the risks. Certainly. Wow, that's a terrifying case.
Yeah, we will show this patient here just yesterday.
Wow. Oh my gosh. That's a
we had
great case.
Consultation with surgery specialist. And
did they have to go to the operating room?
No. Finally,
because
Oh, she got discharged. Wow. Okay.
I used ultrasound bus in this patient. I saw B05, and left ventricle enlargement, aorta dilated.
Wow. That's scary.
Yeah.
It is so scary. We check this is the house out of the feet. It's okay.
Mm-hmm.
It's very rare.
Oh yeah, no, I've never seen something like that.
The lungs damage.
see the lung.
So
Wow.
edema.
Yeah.
It's got like two lungs.
Phóng đại là cái gì?
Oh yeah, big. She had a big heart.
You can see here
A lot of
our
edema.
intersection, the pseudo
Yeah.
lumen
Yeah. Wow.
in the arterial phase.
Oh my gosh.
It's rarely from here. Very
It goes all
high.
the way. Yeah, that's a type A dissection, you said.
Yeah, you can
Yeah,
see in here.
wow.
So,
Wow.
Yeah, very
Goes
terrifying.
all the way down to the iliac. So.
Yeah,
Just
it's damage to the aortic valve, so the patient fall into the pulmonary edema.
And did you say that patient they went home?
Uh,
Did you say discharged?
Because his family, her family don't want to, don't want her to take the surgery.
Wow. That's sad.
Có thai
They
với
refuse.
Dạ xong có thai với
Oh,
mà
shit.
dần
Có hai luôn.
40, 41, 42.
Wow. Oh, that's sad. Jeez.
This is a very long way, right? Iliac actually in two sides.
Yeah, wow. I've never seen anything like that.
Yeah, it also like here, irradiate to here and here. They're very severe.
Yeah. Really interesting case.
Yeah, and here's the fetus.
The fetus, yeah.
They're very severe case. Even when she come here and she was intubated. She was intubated.
Oh, okay.
Yeah. But the oxygen, the level of oxygen is not improved.
Right.
Wasn't improved.
Yeah. I mean, it makes sense looking at that CT scan, how much pulmonary edema she had.
Yeah, very hard case. Very severe.
các bạn còn hỏi gì nữa. Tại sao?
If anybody have more questions after time for practice and when we examine the patient or when we practice, many people can ask Dr. Harrison more and share some experience together. It's time for practice, Dr. Kate and Dr. Harrison.
I think the best way is I think the best way to acknowledge is the practice more first and it's time for
Great. That sounds great.
Vào practice.
Để nói là cách stop.
I have experience about that the patients come to the emergency with hypertension and get drop. Is unconscious. So I check the hypertension. So that I check the ultrasound first. Ultrasound I see the cardiac template. So should I elevate the blood pressure or keep the blood pressure is balanced?
You say the IVC is compressed? Is that what you said?
Cardiac template.
Okay.
Effusion.
Yeah, I mean, I think keeping as much both. I mean, if they're the main way to fix it is to drain the effusion, which is not an easy thing to do. But I think in that patient, in the meantime, I would probably give them fluids, and if they needed pressors, I would give them vasopressors as well, some norepinephrine or something in the meantime, just to temporize or keep them living long enough to get that pericardial effusion drained, either in the emergency department or by cardiothoracic surgery.
Yes, this is my business. Is to check the ultrasounds immediately. So I use more fluids and not with the to evaluate blood pressure. This is the small cardiac effusion and the patient was there. So I think that we keep the blood pressure is balanced.
Mm-hmm.
And they check the CT scanner with the doctor specialist check the CT scanner aorta.
Mm-hmm.
Let's practice.
It's time to hands on.
Okay. Sounds good.
Thanks, Dr. And Charai and Công team.
Harrison, try some tropical root.
Yeah, I don't think I've had one of these before.
Try this.
This one?
Yeah.
You just bite it.
Really nice. Yeah.
You just bite it?
Yeah.
Let's go. Oh, yeah.
Bye, Dr. Dai. Thank you so much.